Welcome, readers and viewers. We are honored to have with us today Dr. Mikhail Gofeld. Dr. Gofeld is a renowned pain medicine physician, clinical scientist, R&D consultant, and healthcare administrator. His extensive research and expertise in neuromodulation, diagnostic and procedural ultrasonography, and innovative treatments for osteoarthritis have made significant impacts in the field. Today, we will dive deep into his insights and gather valuable knowledge on improving our well-being. Dr. Gofeld, welcome to Magazika.
Thank you. Thank you for inviting me. Thank you for the kind introduction. I'm actually going by Michael. Mikhail is more in my previous life.
Oh, okay. So, Dr. Michael Gofeld, let us first start the journey into the pain medicine. Today, like you are in a certain position, you have a certain experience of long years and in this field. But can you please share with us what inspired you to pursue a career in pain medicine and what keeps you passionate about it even after these long years?
Okay, that's a very complex question. The short answer will be curiosity. And I'll give the story. So when I was a third year resident in anesthesia, I was asked, or I was a program in 3 months rotation in chronic pain clinic. So I came to this clinic. It was in 1998, I believe. And I came to this clinic, and every patient comes in, and what they do, epidural injection, epidural injection, epidural injection, epidural injection. So I asked the clinic, the doctor there, she was already in 60s and was very nice and kind to me. And I asked her, Ilana, so why do we do these injections for all these patients? She said, I'll just keep doing it. Like that's what is this is like a standard. Everyone with low back pain will just do epidural injection. And I said, well, it doesn't make any sense. So I started to read. And back in 1990s, there were not a lot of information available, specifically outside of the United States. So, but I found bits of information, and it inspired my curiosity. And then I said, okay, well, it looks pretty unknown and kind of terra incognita, so to speak, that it will be a lot of opportunities for me as a young physician to get in, to learn, to do some research, to help patients and make it maybe different. So that was my first kind of step into the field. And again, at that time, no fellowships were available other than in the United States.
Oh.
And now, interesting enough, I continued not 3 months, but 6 months, because a resident who was supposed to come after me, she got pregnant and she had some, nausea and stuff, and then I stayed there for 6 months. So I learned a lot just from observing. And the next step, I decided to get serious. I demanded from my program director to have a rotation. In anesthesia, we should have 6 months rotation outside of the specialty. And usually people go to cardiology, nephrology, internal medicine, pediatrics. So 3 months, I decided to do neurology. And my program director said, no, you cannot do neurology because it's not in the curriculum. I said, no, it is. And I showed him a book and said, okay, you'll be the first and probably last. So I did it. And 3 months I was in neurology and doing rounds and doing a headache clinic. And that's how I kind of at the stage of my residency got close. So that was my probably the inspiration and motives, because I was thinking it's a very interesting link between basic science and medical science, surgery, radiology, human behavior. It's all it together kind of say, well, it's a lot of things can be done. And I'll just do it. I'll go into field of the pain and I'll figure out what I will do next.
That's a very interesting journey. And as you were explaining the things and you were explaining your journey, you were describing your journey, and very at the end, you said that how it is connected with so many areas. So for our readers who might not be familiar, could you explain what pain medicine covers or encompasses and why it's crucial for overall human health?
So also very, very philosophical, historical perspective question, because let's just not forget that pain complaint is a second after common cold, which I have now, reason for patients to seek help from a doctor. So even though patients come in and say, well, I have arthritis of the knee, what they mean, I have a pain in my knee. If patients, well, I have a slip disc.
Yeah.
Patients come and say, well, I have an MRI with slip disc. What does it mean? So, well, I have pain, right?
Pain.
And I can continue it forever. Now, it's of course, it's a lot of acute pain that comes and goes, but many of these conditions will become chronic. So in this sense, pain medicine is a bridge between different specialties. And we're living in a world that the medical specialties become more and more profiled. Like even within, for example, orthopedic surgery. So some orthopedic surgeons deal only with the shoulders, and some orthopedic surgeons only with hip and the knee and sports. And so now, is it good, bad, or ugly? I don't know. But the point is, if a physician is more experienced in a certain area that is probably it will be good for the patient. The physician will have a lot more procedures done, a lot more cases seen, and at the end of the day will help more patients. But the history of pain medicine is very thorny, because doctors were treating pain from probably about 4,000 years ago, maybe even before. We have all scripts from ancient Egypt and from Mesopotamia and from ancient Greece, and you can see there that doctors were treating somehow pain complaints. But the modern pain medicine started after World War II, and the founder of this modern medicine was Dr. J.J. Bonica, who were he was a military doctor in the U.S. military. He was in the Medigan Hospital on the West Coast, and he made an observation that many wounded warriors, they come in with very strange conditions of pain, with swollen limbs and after amputations, and the pain comes to the point that they become depressed, they cannot function. And so he basically rediscovered that we call now chronic regional pain syndrome. At the back in the days, we call it sympathetic dystrophy. And because he was an anesthetist, he tried to treat these conditions by nerve blocks. And he quickly discovered that nerve blocks do not work by themselves, but they give patients temporarily pain relief. And by doing that, He said, oh, it was aha moment or eureka moment. He said, okay, if we now combine the procedures and at that time nerve blocks with support, with aggressive physical therapy, with psychological and mental health support, with nutrition, will get good results. And he was right, because at that time, it was this multidisciplinary pain management was born. He eventually became chair of the pain medicine in the University of Washington, and he developed this program. This program was initially inpatient, so they would hospitalize patients for 1 month in the hospital. You can imagine how expensive it was, but it was supremely effective. And up until now, there are some inpatients program exists. For example, in Germany, I visited one of them in Munich, or next to Munich. But because of the enormous expenditures, it's kind of fell into disfavor. It was in the United States from, I think, 2084, it was disabled. And what we call now multidisciplinary pain programs, they're really not, because they're not following the same philosophy of the founder. Now, how do I know that? Because I have a privilege to be a medical director of the Unika Center for a couple of years in Seattle. So that was very exciting, and kind of I learned from the source. I could still meet people who worked with this amazing person and started with him this program. So it was absolutely unique. We're trying in all countries and all trying to do some multidisciplinarity, but it's not there yet. So now, going back to your question, doctors in a different specialties, they got tired, basically dealing with patients with complaints of pain that they cannot really help, or they don't want to use their time. And you can imagine, orthopedic surgeon, they meant to operate, but patients coming to them after seemingly successful surgeries and still complain of pain. The classic example, total knee replacement, total knee arthroplasty. 30% of this patient will continue having significant pain, and the prosthesis will be in the same place with no difference. Everything will be fine, but they will still have pain. So they're coming back to the orthopedic surgeons. Orthopedic surgeon look at the picture, say, hey, it's all good. Sorry, it's all good. There's nothing to be done. And they don't know how to deal with them. Many gynecologists that were dealing with endometriosis patients with severe pain, they deal with them, but still not inefficiently. Spinal surgeons, obviously, if the patient comes with severe pain, but there's no indication for surgery, or patient after surgery continue to have, patients after amputations, and they can continue. So it was sort of a push from both sides. So anesthesia took ownership. Anesthesia, meaning as a specialty, took an ownership and translated knowledge of the acute pain management into chronic pain, with pro and cons. It's nothing comes just beneficial. Well, anesthesia created also a problem, kind of the idea that everything can be dealt with injections. And there was a push also from other specialties to unload patients to someone who can take care of them. That's how basically pain medicine, generally speaking, was born and continued development.
Thank you for the historical perspective, kind of from post-World War II, how it advanced. And yes, I have seen, my father used to have knee issues. So yeah, it was all time that there is a pain, and doctors usually ask him that what is the grade of the pain. Yes, I can easily relate to that. Because
by the way, speaking of which, the grade of the pain, we are still using a ruler.
Yeah.
0 to 10.
Yes.
And we apply a very complex personal experience of pain. And there's a layer of pain. And we just ask them the same question. How's your pain between 0 to 10? And it's totally nonsense. I mean, it works fine in acute setting when you have labor delivery or after surgery, that's fine. But asking patients in a chronic pain clinic, what's your pain today? It's totally meaningless because, by the way, one of the grandfathers of modern pain medicine, Dr. Fordyce, he was a psychologist. He was telling all the time since 1960s or 70s. I mean, he passed away a long time ago, but he was telling it doesn't matter the level of pain. What does matter, how pain interferes with the life, and that's important. So the interference score is much more important, but we never ask a patient as a doctor, what does it mean? Okay, you have pain 10 out of 10. What does it mean to you? Or pain 1 out of 10. Yes. What does it mean? What you can or cannot do. That's exactly what is important.
Such a I should say such a functional and healthy insight to deal with the patients who are in pain. You have a strong interest in minimally invasive treatment for osteoarthritis, if I understand correctly. Can you describe some of the latest innovations in this area and their impact on patients' with osteoarthritis?
Certainly. So it's a more complex, complex concept. Now, if we're talking about generalized osteoarthritis, I call it systemic disease. I mean, we call it systemic disease. It's no doubt. Systemic osteoarthritis when multiple joints are inflamed and painful, and degenerative. It's a systemic disease. Now, usually those patients are managed by family doctors, and if they have more luck, they're managed by rheumatology. But the point is, because it's a systemic disease, we are very rarely going into discussion what is actually helpful. Now, many years ago, in a A-list journal in medicine, Bone and Joint, it was published a seminal article that searched or described what is actually the best treatments for generalized osteoarthritis. Now, I will not ask you to guess, but at the end of the day, it was smoking cessation, lose weight, exercise regularly, and have anti-inflammatory diet. It was much more effective than all surgeries combined. Now, why people do not pursue it? For the same reason people actually do not pursue anything. Now you don't need to switch your diet; you just take Ozempic, right? Now you don't need to you don't need to exercise. You can go to physiotherapy and have like massage and chiropractor and so this our ongoing Western laziness, if you will, that we are passive consumers of healthcare or support care without taking any active part of it. And the patient with generalized osteoarthritis, by the way, there are some genetic conditions as well, but that's a different story. Now, if you go of genetics, sure, many people with generalized arthritis, the family history of generalized arthritis, but we forget about epigenetics. So with all these methods, diet, regular exercises, supplements, vitamin, you can shift the bad genetics to a more favorable and get kind of less. Now, why we still have this problem? Again, it's not a medical problem. It's most social or society norms. So it's okay to be obese. It's okay to smoke. It's okay to have diet of processed food because there's no one. I mean, everyone is in a need to be served in the medical field, but that's the situation. Now, In sub-Saharan Africa, osteoarthritis is unheard of, because generalized osteoarthritis, because people usually malnourished, they lean, they move a lot, so they don't have osteoarthritis. It's all in the Western countries. And when Western countries going into other countries like China, people become obese with unhealthy diet, and they have more osteoarthritis. So this is about generalized osteoarthritis. Now we need to separate it from mono or oligo-osteoarthritis. What that means, some person with being very active, healthy lifestyle, playing soccer or playing, basketball, and injured knee in his or her early years. And as time went by, this knee injury will go through a sort of process, and this person will end up with osteoarthritis of the knee. No matter of the healthy style. I mean, you can still improve it, but it's unfortunately it's the natural history of many injuries. And then, what is the solution? So many people resort to injection of cortisone, corticosteroids, which is a standard of care and is covered by our OHIP, and I don't know, thousands or tens of thousands of patients go and do injection of cortisone. Now, I don't have any specific problem with that, except it's only good in my mind, only good as a bridge. Meaning, if the patient has an end-stage osteoarthritis and waiting for surgery, the knee replacement, this is a good time to do cortisone injection. By the way, it must be done under imaging guidance, whether X-ray guidance or ultrasound guidance, because otherwise it may not be injected into the joint. It looks like it's injected in the joint, but it may not be injected in the joint.
May not be.
Now, on the younger patients and who are not candidates for surgery, there's a well-concealed fact that the cortisone crystals destroy the cartilage. There was a multiple in vitro studies and animal studies that basically confirmed that multiple or repeat injection of cortisone into the joint are chondrotoxic. Plus local anesthetics are also chondrotoxic, meaning they create the damage of the cartilage. So we're trying to help. Yes, it helps in inflammation and pain symptoms, but at the same time, those patients who had multiple cortisone injections, they ended up with a knee replacement much faster than others. Let alone other side effects of cortisone. Repeated injection may lead to immune suppression, water retention, shifts in hormonal axis, and they can continue, and osteoporosis. Now, there are some other options, such as viscous supplementation. It's an artificial, used to be from natural source, now it's more artificial. It's a viscous substance that's injected into the joint and created sort of more beneficial milieu in the joint, mocking the normal environment in the joint, and also providing some anti-inflammatory action. So that's number one. Number two is a platelets-rich plasma. Wonderful treatment. It's specifically for knee joint. There are multiple studies published in clinical randomized control shows superiority of platelet-rich plasma. But again, this is a take-home message I usually tell patients. You need to know who does it, how, and what equipment is used. Because in many clinics, doctors use the equipment that is not orthopedic or orthobiologic. It's for cosmetic purposes. So they cannot reach the level of platelets that is necessary to restore the cartilage. So only concentration of 8 to 9 times of platelets higher than a native blood will do restorative or regenerative action,
Okay.
not less than that. There are some other options such as a fat graft, which is basically sample of fatty tissue from the patient, centrifuge it, and inject it also in the knee. So fat has also a lot of regenerative options or regenerative materials, cytokines and anti-inflammatory factors and growth factors to restore the cartilage. Plus, it provides a cushion. So that's also good. More advanced, and it started to be more popular. I'm not telling that is. I don't think it was tested in the really rigorous studies, but there is some option to inject PRP into the bone, into the growth plate of the bone. That is usually used for severe arthritis or sports injuries, and that can also improve sort of feeding of the end plate in a cartilage to grow it. Last but not least is other. By the way, I need to just make it sure now people understand the difference between regenerative options. So what we use in Canada is platelet-rich plasma and fat graft. In the United States, some other places, it's used still and call it stem cells. And it's a big misnomer because there are not such thing as stem cells.
Oh.
Okay, it's a big secret of industry. We right name of this is a signaling cells. So the cells that are mesenchymal signaling cells, they very robust and they attract natural resources of the human body to restore the anatomical integrity and function. But there are not much stem cells. In all these treatments that people go to Mexico and Bahamas, and they're very, very iffy. There are some other substrates that was pushed by industry, such as Wharton gel, some blood products, and some what's it called? I'm blanking now. I will remember it later. I'll feed in the line. They're not really having anything useful other than filters. As I said, usually, my line is the only tangible outcome here is an income. You get the joke, right?
Yes, get the job. Get the job and get paid.
So I want to also discuss, since we're talking about the knee, and that's just an example. There are some other options that become available. One is a radiofrequency ablation of the sensory nerves. And even though I've done a lot of anatomical work to discover these nerves, I do not really believe that the main reason or main innervation of the knee joint is in these sensory nerves that come in from outside. They have probably some influence, but not a lot. Because when I ask patient, how does it feel, your pain? They usually say, well, it's a deep inside kind of, and it's kind of the same what patients pay attention. Patient with a bone metastasis, malignant metastasis, they complain of the same type of pain. It's a deep pain inside of the joint of bone, irrespectively to even movement. So what that means that many the nerves or nerve fibers that are located inside of the bone, they're much more abundant than that's outside of the bone. And we're completely ignorant of this fact. So one of the options has started to become available is, we can expand it a little bit more, is HIFU, high intense focused ultrasound option, that goes deep into the bone and create a focal hyperthermia. It's not enough to kill and kind of to evaporate or burn the field, but it creates hyperthermia, which is basically creates a robust anti-inflammatory regenerative option, which is now I call it thermomodulation of pain. It's not ablation, it's a thermomodulation. And the research has just started how to tackle it, but 2 studies from Japan showed that those patients who, after total knee replacements, who had high-intense focused ultrasound of the knees, tremendously benefited from it.
Thanks.
So that's kind of what I will tell about treatment of focal osteoarthritis, and I'm getting more and more into this field because, you know, I have a privilege to work with 7 great orthopedic surgeons, and they have a lot of patients to feed my practice.
Wow. This conversation is like getting more and more technical as we go off. So last 2 questions, but I will ask the first, like, lighter version of the question first. The conversation that we are having and the profile I have seen yours and the way you described your motivation at the beginning question and everything, you are definitely a very busy person. So how do you balance your professional and personal life? What is kind of your mechanism to do that?
Well, my personal mechanism, I actually took a test on Ontario Medical Association website. There are plenty of tests available, some of them free, some of them for some fee, to test a burnout of the physician burnout.
Yeah.
And I discovered my burnout in average. So, you know, considering I'm more than 25 years in practice, I believe since I left my position as a medical director of the big clinic, and my stress level has significantly reduced. So in the professional life, my principle is to treat patients who I personally think I can help.
Okay.
So, and it's not, many people say about the cherry picking, it's not, because any person deserves attention. Any person deserves medical care. But if I know from the tools that I have, I cannot help a specific person, I would suggest where to refer, like say multidisciplinary pain program or neurology, psychiatry, physiotherapy, but will not take this person because it will be very low yield of this encounter. And by doing so, I actually effectively reduce wait time for my consultation. I think I'm a probably the least overwhelmed by wait list of the patient physician in Ontario, because usually I can see new patients within 2 to 3 weeks. And if I need to do some interventions, it will be within 1 or 2 weeks. So it's like in the United States, I know, very fast and efficient. By the way, it doesn't make sense to see patient today and do some necessary interventions in a year, because, you know, sometimes they come and say, well, I have a shoulder pain. In a year, they have headache. The shoulder pain is already gone. So there's, right? Now, this is the professional part. I also, because of, you know, when people ask me if I'm a researcher, I said, no, I'm not a researcher. I'm a curious physician. So this,
that's nice.
Always,
that's so nice.
Yeah, I'm always interested in new developments and research and basic science. I mean, I do now animal studies, animal labs. We did the human studies, and kind of interesting fact that, you know, since I left the University of Toronto in 2018, I've done more research work than I've done in the university. And it's been very interesting for me to participate and take part of research and development studies. Up until 1 year ago, it was a period of 2 years that I was the Republic of Georgia every 2 months for 1 week. And,
beautiful country. Beautiful country.
Yeah,
I've been
we
there.
did their study. Absolutely unrelated to my field, not pain, but we did study on obstructive sleep apnea device. and they needed me as an expert in ultrasound. But it was fascinating. It was fascinating to work with people from Germany, from Johns Hopkins, from Stanford. Was amazing. So that's kind of inspiring me on the professional part. On the personal, I can tell you, I mean, I do yoga almost every day. My wife is yoga instructor. She went to Mysore multiple times to Patabi Joyce Shala, and I do yoga every day almost. I mean, not now because I'm sick, but I don't do it as properly 1 hour and a half, but I do half an hour, and Sunday I have a long practice, all series, first series. I do. I mean, I eat usually, I mean, most of the time I eat well. Sometimes I have a craving hamburger and I eat hamburger, but it's not every day. I mean, every day is mostly plant diet, fish plant. I do regularly detox. I do fasting every month, so 2 months. I don't eat heavy breakfast. I actually don't eat breakfast almost at all because I'm a big fan of more metabolism promotion by fasting, intermittent fasting. I don't do proper fasting, but I still think people should not ever eat when they're not hungry. It's not good for your stem cells, mitochondria. You need to improve it. And I do hypoxic training.
Oh wow, that's a very combined effort, and I really like the term that you have said. I really liked it. Curious physician. That resonates so much with your
Yeah.
activity, and the policy that you have said that with a high yield you choose the patient. It is not cherry picking. It is picking with care.
Yeah,
It
that's
is
exactly.
picking with care. You care for the patient. If you cannot contribute, you feel like that you cannot contribute, you guide them to the proper way.
Yeah, I mean, kind of imagine if spinal surgeons will take every patient who comes with a low back pain to a surgery,
Yeah,
it would have been a disaster.
yeah, for
Okay?
sure, for sure.
Which, by the way, happens in the south of border, like in Texas. It's interesting story. In Texas, over the once in the past, they did a study because the amount of spinal surgeries was going up like exponentially. So they tried to figure out a study and see why. And also
Okay.
maybe something's going on with the patients, and they did multiple analysis. So they found only one variable: amount of spinal surgeons. So the population remained the same. The amount of spinal surgeons who came to Texas increased exponentially, and hence amount of spinal surgeries increased exponentially.
Wow.
It's a bad medicine, right?
Wow. So so many areas to cover, but we have to be conscious about time and everything. Very briefly, if you can say that, as we have today's kind of pain medication, that was our topic. We have a lot more other to talk with you: neuromodulation, ultrasonography, your latest research and development. But for today, how do you see the future of pain medicine, and how do you see yourself in it?
So I see pain medicine. I don't see really pain medicine as many of my colleagues see as a longitudinal care. Like many pain clinics, and most of the pain clinics in Ontario, they focus on providing mostly injections
Yes.
regularly, frequently, starting like once a week, once in 2 weeks, once a month, and keep going until the quote of Voltaire and said, "Mother Nature will cure the disease, and doctors will until doctor entertain the patient." Right? So it's bad medicine. There is no reason to do injections. There's no reason to call them nerve blocks because they're not nerve blocks. When I ask patients about do you feel any numbness after the injection? The doctor A did, said no, so there's no neuroblocks. Those are just do injections. No, those injections are most of the time kind of providing sort of feeling of warm numbness, muscle relaxation, but they're meaningless. I always advocate against injections without clear anatomical diagnosis. And I think it's totally dishonest and unethical to subject a person to endless injections, even though they believe they help. Our brain is a very powerful factor. Our brain generates endorphins and dopamine all the time. You create this cue, doctors create a cue, they create prompt, and patients keep going in this vicious cycle. So I see pain management or pain medicine is probably more I like to call it pain medicine as a science, not enterprise, as a consultant role. So I see patient today, I will give patients advice, I will send advice to a family physician, I will do some focused interventions, and hopefully those interventions will help. Interventions based on a precise anatomical diagnosis. I see MRI pictures. I don't read reports. Even though I trust radiologists and they're great specialty, but the problem with that, they do not have enough information, so they just generate a general report, and many times very important things are missed in a report, such as disc tear or fatty atrophy of the muscles in the back. So I read images, and I kind of try to create an anatomy-based diagnosis and provide treatment. Now, then I will see this patient. If I succeed, I will see this patient every 3 months, every maybe 6 months, every year. Sometimes even less than that if they need my help. So that's why I see a lot of new patients and don't have this kind of the roster of Swifties, right? Swifties in medicine that are coming to my clinic all the time because I need to give them something, right? So that's why I call pain medicine, and it's very kind of delicate balance when you're not slipping into more business side of medicine and keeping with good ethical practice and helping patients.
It was like a total paradigm shift for me, because I've seen my father struggling with knee, and he has been treated in 3 countries. I have never heard this kind of conversation with him because I was present there. My mom was present there. So in future, the science of pain medicine, you do more and more anatomy-based treatment, and your curious mind will endeavor.
And I would like to see. So we physicians in the community, it's a backbone on medicine anyway, right?
Yeah.
So I think the future of our care is to be patient focused, patient oriented, but not to slip to patient directed care. I know what that means. Like patient directed care, the patient tells you what to do, and doctors do it because they want to get satisfaction rates.
The other way around.
So patient oriented, patient informed, but not patient directed. I would always like to see development of the pain medicine in a country, in Canada, more aligned with kind of universal principles of education, and unfortunately it's not there yet. I would like to see multidisciplinary programs that government is funding to be more efficient and kind of go back to the source, go back to the bonica, and see how we can help patients. Maybe not all of them, but to take those patients who really just need to be treated in multidisciplinarity with biopsychological problems, and have some support. I do not think the future of pain medicine is to medicalize social problems. That's what I can tell you, because it is different, all other type of discussion, but social problems such as, you know, poverty, addiction, unemployment, they cannot be treated medically. And let's face it, you know, and so the last, maybe I can tell, like there was some times ago was a publication in the United States of the pain landscape and economical landscape in the United States. So they said, well, the pain is one of the worst or leading components of disabilities, more than cancer, more than heart disease, and it's basically more than $6 billion loss. So I said, okay, if that's so, why we don't see the shiny pain institutes all over who can help, you know, patients? And instead, pain clinics are usually in the hospital, somewhere in a dungeon, and very, very fragmented. And we see this gorgeous, you know, multi-level building of Cancer Institute and Heart Institute, and it's good. But if that's so, if this pain is really that severe problem, I would not have any significant funding for that.
Oh. Fantastic, fantastic. So with that powerful and proactive vision, we end this conversation. We are at the end of this conversation. Thank you, Dr. Michael Gofeld, for being with us today and
Thank you.
enrich us with beautiful insights.
Thank you.
Thank you very much.
All the best. Bye.